Thank you, Derek. Thank you, Stephanie, and John, and thank you all for inviting me. This is an absolute privilege as a trainee cardiologist in the UK, and I think perhaps in most of the world. No one could escape the influence of Lionel Opie, and it was particularly moving and important for the thought of a cardiologist to meet Lionel Opie and to become friends, a mentor, a friend, someone who could inspire with his own broad knowledge and his incisive analysis in all problems cardiovascular. And it's a real huge honor to be asked to give this named lecture. And I'm going to take us on a slightly different trajectory to introduce you to, and I think it probably doesn't need introduction, but maybe it does, the concept of cardio-oncology, which is the appropriate way round when I'm talking to an audience primarily of cardiologists, but of course if I'm talking to cancer doctors, it's oncocardiology. So, a little bit of background. Our colleagues in oncology have been remarkably successful over the last few decades, so that more than 50% of adults and probably 80% of children with cancer can now be expected to survive for 10 years or more. And here's some data from the UK. This is childhood cancers, a number of different cancers. And you look here across the years, not particularly up to date, but things have continued to improve. So you have some cancers that are curable. Now, with increasing numbers of heart failure, of cancer survivors, we are seeing individuals who suffer the consequences of their disease and the treatment that they're exposed to. And it's very difficult to get accurate figures at the moment, but in adult heart failure, somewhere around 10%, 5 to 10% of those individuals may have developed their heart failure after exposure to cancer drugs, and perhaps due to damage incurred at the time of their treatment. And the biggest culprits, perhaps historically, and the ones most investigated in detail, are the anthracyclines, and also, and I'm not going to have time to discuss it, radiotherapy, which amplifies everything I'm going to tell you that is damaging to the heart and circulation with drugs or cancer is amplified if radiotherapy is involved. There are newer drugs, and they're bringing newer insights into myocardial damage and myocardial adaptation, but there are also newer challenges and problems. Now, Lionel was a clinical scientist, spent his years in laboratories understanding the metabolism of the heart, and through that, his great understanding in therapeutics. And understanding the mechanisms for a lot of what I'm going to talk about is, at best, incomplete. So we don't understand all the methods of toxicity, and particularly the longer-term effects. And the strategies that we have to apply are therefore, without a knowledge of many mechanisms, can be somewhat limited. And the number of prospective trials upon which we can determine how to treat individual patients are relatively few, modest in size, too short to answer many of the questions that we need answering. So if we look at this, the wonderful statistic that 80% of children may well survive their cancer, but it has many, many potential consequences for the individual patient. And the cartoon on the right illustrates what this might look like. This is cardiac performance, cardiac function, which immediately after treatment with an anthracycline, the commonest used, doxorubicin, you have a period of impaired function, characterized often by the appearances that are consistent with a dilated cardiomyopathy. Then there is a period, a latency of up to 10 years or more when everything looks normal, to be followed much later by a decline. And in summary, anthracycline-induced congestive cardiac failure, perhaps 2% at 2 years, 5% at 5 years, overall 3% within 6 years. These are children. And the implication of anthracycline-induced congestive cardiac failure is very severe indeed. It tends to be more severe than myocardial damage achieved or suffered by other methods. And I think the other thing I'll just point out, children are not small adults, and particularly not when it comes to these responses. So here, adults, there is a relatively low incidence these days of acute anthracycline-induced toxicity in children, and we'll come into the reason for that. In adults, it's a higher incidence, perhaps in some, it's difficult to be precise, but maybe up to 11%. I think that's an overestimate today, but somewhere around that region. And adults, many, particularly as we're treating older and older patients, many have pre-existing cardiovascular disease, other comorbidities. We know that in children, before the late development of damage, there may well be a very long latent period. We don't precisely know latency when it comes to adults. The myocytes are different, and you're dealing with a mature, possibly senescent population when we come to looking at adults. So if we look at breast cancer patients, very vaguely and roughly, cardiovascular deaths begin to dominate the picture 7 to 10 years after recovery from breast cancer. And the cardiovascular risk of breast cancer survivors is more or less doubled. Here are two different studies showing essentially a doubling in cardiovascular risk in these survivors of cancer. We all know this is a very rare instance when we know the precise timing of the insult. And to me, that means as clinicians, we know the timing of when we should be undertaking interventions and preventions. So I won't expect you to be able to read that, but this is a registry, UK population-based cohort study, adults who'd been alive 12 months or more following cancer. And this is the time, large numbers, 126,000 cancers, 630,000 controls. Along here, you have the risk, 2, 4, 8. And these are a list of different cancers, and this is for coronary artery disease, and you can see this variability. Some cancers do produce an excess risk in terms of coronary disease, and the pattern might be different for arrhythmia, and it's different for heart failure, and it's different for stroke. So it's a complex issue, an interrelationship between the precise cancer and its treatment and the effects on the entire cardiovascular system. Now, we'll get more granularity where this is concerned with the Vicori Collaborative, which has been set up, and this has got much bigger numbers. John Deanfield's involved in this. I don't know if John's still here, but this is going to link together cancer and cardiovascular registries, looking at 6.2 million cancer diagnoses and 3.8 million hospitalizations for cardiac events. We'll begin to tease out who is at risk, which cancers, what sort of treatments, with a much greater detail. This cartoon just begins to hint at the complexities here. I'm going to look, if we look at acute effects, we have the numbers of different approaches to cancer. For instance, if we look at platinum-based compounds with primarily a potential deleterious effects on vascular endothelium, you've got antimetabolites, you've got radiation amplifying all those effects, which many clinicians will be very familiar with. You've got the HER2-targeted therapies like trastuzumab, and pertuzumab, affecting myocyte function and producing acute heart failure. And of course, I haven't got time, sadly, to go into all of these, or perhaps thankfully. And what I'm going to do is concentrate initially on these which are the paradigm of myocyte damage, and that is the anthracyclines, and looking at their potential to produce acute myocyte damage and acute heart failure. To go back to the legacy from Lionel, understanding some of the mechanisms should give us insights on methodologies to try and improve the situation. So in the acute phase, the cardiac toxicity, the first reports began to appear, and they appeared in the Lancet in the form of letters. The anthracyclines have begun to be used in the late 60s as very important cancer therapies, and they still are used in up to 50% of all cancers, so they're still very, very prevalent. And the clinical features began to become clear, that the damage to the heart muscle was dose dependent. It was dependent on how you gave the drugs, whether it was bolus or you could mitigate by giving infusions over greater periods of time. And it was noted that children were sensitive to these toxic agents, as were older adults. There is a very complex number of events that occur within the myocyte in response to anthracycline exposure. But some of the major features are a tendency to increase free radicals, increase reactive oxygen species. You have interference with normal mitochondrial function. And by the primary effect of anthracyclines of binding onto topoisomerase 2 beta, affect DNA and cause DNA fracturing. And that leads to sarcomere disruption, and you have this whole gamut of effects, some of which are related to their cancer toxicity, and that is their efficacy, and some which perhaps spill over to produce effects that are unwanted. Again, it was noted clinically that not only was there acute, immediate toxic effects with the production of heart failure, but there was a subacute problem which might take a year or more to manifest with a gradual deterioration in cardiac function. And then, of course, as I've mentioned already, this very late presentation. So in summary, just to be really straightforward, cardiomyocyte damage mediated through production of reactive species, mitochondrial dysfunction, DNA damage, and the neuroregulin ERBB pathways. And those acute changes, they induce apoptosis, they mediate the acute effects. It's not yet absolutely plain how that translates into the long-term toxicity and cardiac dysfunction. Some of it may well be the accumulation of anthracycline metabolites within cells that cannot be excreted from the cells. So we know that infusions versus bolus help, and there are a number of different potential toxicities with the different forms of anthracyclines, of which there are up to 200 different versions. Doxorubicin is the one that's mostly used, with a 5% toxicity in cumulative doses of 450 milligram per meter squared and above. You can see here the myocardial and actual cardiovascular cellular effects and the injury responses that are stimulated by these drugs are really legion. And you can, and I think it's fair to say that this is a multifaceted injury. It's an insult to not only myocytes, but to endothelial cells and to the surrounding tissues within the heart. In a simplistic way, to my mind as a clinician, if you have such a multifaceted injury, it's likely that you're going to need a multifaceted approach to protection. I've worked closely with Derek for nearly 30 years, and the Hatter Lab has been developing methods to protect the heart from ischemic damage. And it was a simple jump of faith to see whether the methods used, particularly conditioning and preconditioning, could this have a role? This is a simple experiment done in our labs where we looked at isolated myocytes in a test tube. And we looked here just counting the number of deaths. They were allowed to be suffused with doxorubicin, and after 18 hours, you see how many survive and how many don't. So here we are. If you do nothing, the proportion of cells exposed to increasing doses of doxazosin, number of cells dying increases. by exposing those cells to a short period of hypoxia before receiving doxorubicin, that is, an ischemic preconditioning, you can protect those cells. That was intriguing, that's interesting, and that's been perhaps brought forward by much more sophisticated and elegant work from Borja Ibanez in Madrid. And he's got a model of anesthetized mini pigs where they infuse anthracyclines into a coronary artery. And they've been looking also at ischemic preconditioning, but not of the heart itself, but remotely. They make a limb ischemic for a few minutes before infusing the doxorubicin. With doxorubicin, you get the expected damage to mitochondria, you get the later profound changes to heart structure with fibrosis and severe cardiac dysfunction. With exposure of remote ischemic conditioning, those problems are diminished, not removed, and you can see here the benefit with ejection fraction. We have just finished a small pilot study we called ERIC-ONC, where we looked at adults undergoing anthracycline therapy in whom we were going to try and explore whether remote ischemic conditioning of the forearm would protect them from the damaging effects of doxorubicin, and we were measuring that in terms of troponin release. So eventually we just finished this, 30 in the control, 30 in the intervention group. They received 5 minutes, 3 5-minute inflations at 200 millimeters of mercury. And we looked not only at biomarkers, but at echo and MRI, and we followed them up to 12 months. This is preliminary data, but I just point out we've managed the average age about 50, but it's important to note because of where I work, most of the patients, 80%, this was the first diagnosis, but the number of patients were mostly composed of sarcoma patients with a pretty big number of lymphoma and only a small number of breast cancer patients. We were interested in whether you could detect an acute jump in troponin after each exposure to anthracycline, and here we have cycle 1 to 6, but there was no immediate 3 to 24-hour jump in biomarker. However, as you can see, by cycle 4, this is mean troponin Ts, they all go up. And in summary of these preliminary findings, where am I? There we go. Troponin T, and we also looked at the cardiac myosin binding protein C, was abnormal in 81 to 92% of these patients, peaking at about 1 month following their last exposure to anthracycline. As you can see here, this is the remote ischemia versus sham. There was no difference in troponin excretion in our two groups. Interestingly, for me as a clinician, I don't know how many of you have had a cuff up for 200 millimeters for 5 minutes. It's uncomfortable. And I was expecting a lot of patients to say no, no more. Interestingly, not a single patient failed to have 3 inflations to 200. We had no changes in cardiac function. We've had no difference in MACE events or, importantly, in cancer events. We're not preventing doxorubicin potentially from being helpful. This, again, we may get more insights. I think ours is a small pilot study, like most small studies, had lots of areas where you could criticize it. Did we give too little? Was it not enough? Was it the wrong sort of conditioning? There's a much bigger trial, again, from Borja Ibanez and his group in Madrid, which it's called the Resilience Trial. They're looking purely at lymphoma patients, so that's another area, looking at a single cancer group, and they have to have at least one cardiovascular risk factor. The primary endpoint is going to be cardiac function by CMR, and they're hoping to get over 600 patients. I hope this will give us more insight into what could have been a useful, non-pharmacological way of protecting patients. We will see. So I just want to, there are lots of other things in the in the frame for potential protection. And this is something from Kirsten Tim and her group in Oxford, looking at a really important kinase, AMP kinase, which its function is impaired. Why is this important? Because it is central to many of the issues that are damaged by this drug. It is central to mitochondrial biogenesis, to all of these areas. So a very central agent. And the interest for me is that activation and enhancement of AMPK function might be able to be achieved by medicines that we are very familiar with as clinicians: statins, metformin, resveratrol, dietary restriction, exercise, and specific AMPK stimulants. So worthy of looking at. But before I venture into more and more hypothetically useful approaches, what do we know so far? Well, this is from the group in Milan led by Cardinali, and her group were the first to really demonstrate this clearly, that if you give conventional heart failure treatment in these groups with ACE inhibitors and beta blocker, you could have individuals with anthracycline-induced reductions in function, they would respond and function would improve. However, you had to give it early to get any benefit. If you left it after 6 months, there was no benefit. And this is important because many of these people get changes in ejection fraction that are asymptomatic. So you have to have ways of being able to detect what is happening. If you get established heart failure, you can look at the survivals, 85% at a year, only 50% at 5 years, which is a bit of a tragedy. Again, I'm not going to show you this. So where are we? If giving it early, giving it before you're going to treat the patient with the toxin seems rational, and that, of course, has been looked at. And it's wrong to deny these individuals, I think, particularly if they've already showing signs, it's wrong to deny them medicines that we know are helpful in heart failure. And there's some data to suggest that is a very reasonable strategy. But what if you try and give it before? And there are a number of studies that were reviewed here just a little while ago. You can see the size of the studies is small, and there's nothing definitive here that gives us an absolutely incontrovertible lead that giving people either beta blockers or ACE inhibitors or both, or neprilysin inhibitors necessarily protects. We just don't know. I wouldn't say it's no effect, it's just not being demonstrated beyond shadow of doubt. So if we look at conclusions, the routine use for primary cardioprotection not currently justified. In our practice, we absolutely do. If we have people at very high risk, we optimize their treatment. Whether we're doing any good remains to be seen, but I think we do. And their use in subclinical, completely asymptomatic patients who've had a reduction in ejection fraction, do you treat them? And if so, for how long? Important issues, not yet fully resolved. There is one form of treatment that is incontrovertibly helpful, and this is a medicine called Dexrasane, quite an old drug, it also binds to topoisomerase 2 beta, and it binds up here, and it prevents anthracycline binding as well. And it has good evidence in childhood cancer of preventing cardiotoxicity. There is evidence in adults also. At the moment, it's only licensed to be used in women with advanced metastatic breast cancer if they've had already an excessive cumulative dose over that. But that is known to work. I'm going to move on a little bit. I'm going to move on to some newer areas briefly in the last few minutes. So this is a recent, we predicted the Higgs, we predicted gravitate, we did not predict this, and I'm going to talk about cancer immunotherapies because that is taking, we sort of know what to expect with anthracyclines. I know what to expect, the oncologist knows what to expect. We did not know what to expect here. And why are these making such a noise? This is, I've just chosen one, this is the survival of a really severe disease. This is advanced, often metastatic melanoma. Historically, out at 36 months, 15% survival. And if you look at these newer drugs, particularly used in combination, we're now looking at 60% survival. So they are increasingly used, they are extraordinarily useful medication, but where the heart is concerned, there have been signals. Now, mainly with these immune checkpoint inhibitors, you have gastrointestinal side effects which are quite common, sometimes quite severe, but they can be managed and they're expected. But what I'd like to highlight to you, which was highlighted to us, and I'll illustrate why, is just down here, a myocarditis, which is really quite uncommon, quite rare. The problem, if you get it, the mortality associated with it approaches 50% acute mortality. Now, why is this a problem? And I'll give you an example. This is a lady under our care with a Merkel cell carcinoma, metastatic, difficult, had previous treatment which she'd failed, and she was switched to an immune checkpoint inhibitor combination. After cycle 2, she has rather vague symptoms. Sorry, this has all gone strange here. She had fatigue, myalgia, but the myalgia is associated with creatine kinase of over 10,000. And of course, the troponin was done, which was over 700. We undertook, not immediately because there were time constraints, she had a CMR, cardiac scan, which revealed evidence of edema, evidence consistent with the diagnosis of myocarditis. And if you look here at a troponin T, in our lab, under 14 is normal. We're talking thousands in this woman, and we're talking thousands that are maintained. I've just highlighted this output from her clinical notes over many, many weeks. These are the patients where in the literature have a risk of sudden death. She was feeling relatively well. The difficulty in her was keeping her in hospital, keeping her under observation. She had huge doses of steroids with initially not much effect. Mycophenolate was added. We were desperate, but eventually it resolved, and troponins, this is still 200, folks, months later, gradually reducing to normal. Now, significant risk of sudden death, so you've got to detect this. She did not have much in the way of symptoms. Paucity of cardiac symptoms, responded to steroids, she's well, but difficult. I'm going to do another one. We have probably one of Europe's largest CAR T-cell programs. The cartoon here explains how this is done. So this is a previously extremely fit 32-year-old man who has CD19 specific. CD19 is not expressed on heart muscles. It shouldn't affect the heart. No pre-existing comorbidities, normal echoes. So he has his CAR T infusion, and 4 days later has a very typical, recognized, the cytokine release syndrome, associated fevers, tachycardia, a bit of low blood pressure, not too bad for him. He was hypoxic en route air and having trouble breathing. So he had, as we would do, an anti-IL-6, toxicilumab. This is the standard care treatment, and his CRS clinically resolved. He didn't. He remained hypoxic, he was symptomatic, and at the bedside had obvious signs of heart failure. He had an elevated BNP, troponin did not rise. He had global dysfunction at this point, 41% in a young, fit bloke, very not good at all, and he had evidence of edema and moderate effusions. So he's treated as we always do as cardiologists. He has standard anti-heart failure treatment as far as blood pressure allows, and actually did improve. Asymptomatic, complete response in terms of his unpleasant, aggressive cancer, and he's asymptomatic, and 5 months later he has a normal MRI. We don't know how to handle this. We don't understand the basics. We don't know how best to do it, how long you continue with treatment on people like this. So we have actually a prospective study which we're undertaking with Claire Roddy, who heads up the CAR-T program at UCH, And so far, we've got 88 out of the initial proposal for 100 patients with very close cardiovascular phenotyping throughout and up to 3 months post-CAR-T. We will see if there is an issue and how we should perhaps manage it. Okay, just final few words, if you forgive me, that I want to range, having gone to the minutiae and the esoteric, to something more broad-based that opens up the possibilities for all of us clinicians in this room to be able to help. So the metabolic syndrome in cancer survivors. So this has been known about for a while, and I'm illustrating here some data from St. Jude cohort. This is an adult population who have survived cancer in childhood or in adolescence. And in their group, 30% had the full-blown metabolic syndrome, however they defined it, which included the whole gamut of insulin resistance, obesity, hypertension, hyperlipidemia. So 30%. And that's about, at the time of this, about 40% more than you'd expect for this population. Now, the important point is only 4% of this population were adhering to any kind of lifestyle intervention or therapy for their metabolic syndrome. Now, that's a gap. That is a big gap. And if we look at components like hypertension, it's much more prevalent. It's a really big problem that is absolutely not addressed or treated, and the implications in this group are sinister. So the other area where we see it a lot is in hematopoietic stem cell transplantation. This is a burgeoning. If you talk about tsunamis, we think somewhere around 70,000 stem cell transplants performed per annum, going up by 10 to 15%. The metabolic syndrome prevalence in adults is 40%. The risk is much higher if you're older, odds ratio of 9. And the risk of a cardiovascular event, if you have a transplant and survive it without metabolic syndrome, the risk of a cardiac event, about 9, still high, but it's only 9%, 27% if you have this. Interestingly, this model of chronic inflammation, which is graft versus host disease, didn't, in this group, relate to the metabolic syndrome, so it didn't seem to affect the incidence there. But it does increase cardiovascular risk by up to 5-fold. There's no difference between autolytic and anogenic. Okay, for my last 3 slides, I think, I'm just going to talk about what Derek always kidded me on. Many hats I wear. One of them was in cardiovascular rehabilitation. I've been running that for many, many years at UCH. And deconditioning, one of the bottom of the lists of problems in people who recover from cancer, but it is a big issue. And the reason that's important is that you can do something about it, probably, or at least you should. So if we look at it here, these are childhood cancer survivors between 5 and 20 years after their cancer. And we're just looking here at a measure of how limited they have become. And you can see that their limitations are 30% limited in the 35-year-old. So significant limitations. They feel limited. They're not as able to do things as they used to. There's a lot of data in individuals with childhood Hodgkin's lymphoma survivors. You can see here those, in terms of the incidence, those that are doing less than 9 MET-hour equivalent per week have a higher incidence of cardiovascular events compared to those that do more exercise, more coronary disease, more heart failure, forget about the valves. And here, compared to a group that do nothing, the more exercise, the less your risk. Again, a bit of an important point here in terms of women survivors of breast cancer. If you look at their Vmax versus age-matched control, this is a particular cohort of 250 patients. Throughout their career, if you like to call it that, of breast cancer, they are performing much, much worse than non-breast cancer. And you can actually, if you want a take-home figure, undergoing treatment for breast cancer with or without radiotherapy. Radiotherapy makes it worse. You age your heart and circulation by 20 years. So your exercise capacity of a 50-year-old woman becomes that of a 70-year-old. So the reasons behind that are multiple, complex, but they can be mitigated. So we know from animal experiments that if you exercise rats before doxorubicin, their heart does better. Exercise in people with cancer has been going on since 1986. But 34 randomized trials reviewed here. There are some benefits. I mean, we've done a very small trial. The benefits are primarily in exercise capacity, i.e. make them a bit fitter. We don't know in overall outcomes in terms of cardiovascular mortality or morbidity, but that will take much bigger interventions. But this is a group where you can intervene because you know when the insult happened and you can follow them, and they are usually very well motivated. So finally, to conclude, the answer to your question, Derek, cardio-oncology treatment still far from the limits? Yes, an awful long way. Not only in terms of drugs, but the application of even the simplest thing, like lifestyle intervention, exercise therapy, is just not there. And I would say to you that actually this is a really complex area of medicine. It's a fantastically interesting area of medicine, but you can't rely on just the ad hoc presentation of these patients to your general cardiology clinic. You need to have methods where you're going to detect relatively low frequency events, but they have high impact for the individual. You need to have some kind of link with your oncology services. The world's worst thing for a cancer patient is to have their cancer therapy interrupted or reduced through the belief that they've injured their heart. Sometimes we found often before we did this formally, before we had formal protocols, people were having their cancer therapy stopped because one echo showed an ejection fraction of 55, the next sort of 53. They said, oh, something's happening. You know, that sort of problem. And I think, again, we have a responsibility. We know what to do with many of these patients. We have lots and lots of medicines out there. They're just not being used. And we need to make sure that they do, because that makes sense for the individual and for our society. And we have a lot of things here, a lot of things to look at that may well help. So with that, if you've been listening, thank you very much.